Hi, everybody. I know most of you know me. It's good to see old friends. I love coming every year and getting to see your kids grow and just visit. And thank Hunter's Hope again for doing this because it's really amazing. And I don't know that there's anything else like this, certainly not in my life. And I think it's really special and really important. And I can't believe how many years it's been. I'm going to talk today about treatment of Krabbe. I'm going to go over some old things and some new things. And like always, if you have questions, just ask me. I have to show you my disclosures. And I'm going to start reviewing a few things. So I work a lot with umbilical cord blood as a donor for transplant, which is one of the treatments we use for Krabbe disease. And the reason we work with cord blood is because it has cells in it that are more able to get to the brain than cells in the bone marrow, which is the traditional source of a donor for a transplant. And with the story for cord blood goes back to really the mid-'80s when Hal Brockmeyer, who's the guy with the tanks, discovered that there were blood stem cells in cord blood. And then when a transplant was done, actually in one of my patients in 1988, by Elian Gluckman, the doctor in the white coat in France. He's a 5-year-old, had a genetic disease called Fanconi anemia, which is fatal in childhood and needs a transplant. And his baby sister happened to be healthy and a match. And we saved her cord blood, sent it to France, sent the family to France. They did the transplant and it worked. We sent them to France because Dr. Gluckman had the best experience with this disease, which is a very hard disease to transplant. But it proved that there were blood stem cells in cord blood. And Matthew, the patient, is alive and well more than 37 years later now. That's a picture of him with me a few years ago. And his blood is still populated with his sister's stem cells. So that proves that cord blood has blood stem cells and led the way to using it as a donor for transplant. And if we fast forward to today, there have been over 50,000 cord blood transplants performed around the world. And a lot of them are for patients that don't have a donor. But in the case of leukodystrophy and particularly Krabbe, where you don't have time, you're in a rush to get that transplant as fast as you can. The cord blood is kind of off the shelf. Literally, if you know what you're doing, you can get it in 5 days. When we're really trying to get kids to transplant fast, it makes a big difference. And then the added benefit of cells going to the brain makes it the best donor choice. I will say something, you guys probably know it, but if you have new patients with Krabbe diagnosed through newborn screening, no one should let the program look for a matched sibling donor. First of all, most matched siblings are carriers, and that's not a good donor. Second of all, it takes 2-3 weeks. That's too long. And third of all, there's only a 1 in 16 chance that it's going to be a donor who's a match, not a carrier. And it's not cord blood. So for all those reasons, that's a sign they don't know what they're doing. We all know what Krabbe disease is and what it's caused by. Most of the treatment has been focused on the infantile form, which means the form where a baby is going to develop symptoms before a year of age. And that is the form now that it has been approved to be added to the RUSP for newborn screening. And as Dieter, I don't know if Dieter's still here, but as he was talking about, that means psychosine greater than or equal to 10. And if that's the case, we know it's an emergency and we know that baby has to rush to treatment if that's what the family wants to do. Now, timing of diagnosis really depends on a lot of factors. Sometimes there's unfortunately a family history and then another pregnancy, and the diagnosis can be made in utero. You can make it as early as 10 weeks with CVS or 16 weeks with amnio or around the time of birth. And if there is a diagnosis in a family, all other siblings in that family should be screened so that you know if they're affected or if they're carriers, and appropriate treatment and genetic counseling can be obtained. We all know now newborn screening is approved. It's on the RUSP. It will be implemented in many states, hopefully quickly. Takes a while. It's not going to happen tomorrow, but hopefully over the next few years, all 50 states will be screening. And when babies are picked up through newborn screening, we have other options for early treatment, particularly if it's the infantile form. One thing I would just say quickly is a lot of moms now can opt in for screening after they're pregnant. But to me, that's it's better knowing early, but it would be better to screen before pregnancy if you're going to pay money for screening. And that really isn't implemented yet. It is, for example, in New York for Tay-Sachs disease. When you get married, if you get married and before you have your kid, you have to get the marriage license, be tested for Tay-Sachs. But I'd love to see something like that for all leukodystrophies in all states, because knowledge is power, and whatever option you choose, at least you know what options you have. And if you know you're a carrier and you're at risk for having a baby with a leukodystrophy, you can do what's called pre-implantation diagnosis and produce healthy embryos, which can then result in healthy pregnancies. Dieter talked about diagnosis, so I'm going to skip this. But I will say that if a child screens positive with a high cytosine, then there's a whole bunch of tests that should be done to determine if they have active disease. Those tests are listed on the right side of the slide, the most important being the MRI and the nerve conduction, because they're usually abnormal even in a newborn who looks fine. And that will determine timing for whatever therapy options that particular baby has. I also want to say that in all situations, supportive care is incredibly important. And that means whether you transplant or you have gene therapy, you have some new therapy that's going to come in the future, or you've opted on supportive care and not to go to transplant or gene therapy. There are many, many ways to optimize the health of that child. And I don't think it happens enough. That's what the care centers are about. I'm blanking, but the leukodystrophy care networks. But I really think we don't pay enough attention to this, and pediatricians often don't know how to do this or get the right resources for patients. One is to minimize spasticity, watch for bone health, because kids who don't stand get very weak bones. It's like premature osteoporosis, and they're prone to fractures even if they're just moving. Pulmonary support to prevent pneumonia and aspiration, GI health to manage constipation. I know a lot of people are afraid of G-tubes, but I like to say G-tube is your friend, because it makes it much easier to feed a child who's having trouble with oral feeding, and you don't have to take bad tasting medicine, which makes some kids use their mouth better if only good tasting things go in. Nutrition is important as well. Enhancing communication with whatever assistive devices that child can use is really important. Preventing seizures, managing pain and irritability. I know babies with Krabbe and many children with Krabbe can't talk to us, but they act like they have pain. And some of the older patients we know who can talk to us have told us they have pain. Drugs like methadone really can help, chronic methadone, Ativan, Neurontin. There's a whole menu, but there are drugs that can really help these children be more comfortable and have a better quality of life. And then schools, psychosocial support is really, really important. And I know it's challenging, and I don't think we do enough, but I wish we could do more. Now, I want to talk about gene therapy because I know you all have questions about it. It's experimental, number one. There were 3 companies working on gene therapy for Krabbe disease. Unfortunately, 2 of them stopped because of quote unquote business decisions, not because something was wrong with the therapy. There is one company that is still in there and has an open phase 1 trial, and that's Forge. Passage Bio had a trial to give the vector gene into the spinal fluid. They treated 1 patient and then closed the trial because they said they had inadequate resources. And Neurogene was planning a similar trial, but again, they never even got to the clinic. They closed the development of the trial, again, for financial reasons. And it's unfortunate, but in the rare disease space, There aren't a lot of patients. It's not a big market. It's complicated therapy. It's hard to develop. And there just aren't big incentives for big pharma to do that. We have to work on that. But the good news is Forge has a trial. It's phase 1. It's ongoing. The hope is now to treat some pre-symptomatic newborns, after transplant, probably been diagnosed through newborn screening or a family history. It's an intravenous AAV10 gene therapy. Baby has a transplant, and then after recovery from the transplant, which has to be minimally 20 days, but could be much longer, they get a single dose of the IV gene therapy. There are 5 kids that have been treated at a low dose level, and there was no safety concern. And they are now starting the high dose level, and this year there are 4 slots at that level. I'm telling you the details because it's important to know you can't just call up and say, we want gene therapy, we're coming tomorrow. There's a lot of eligibility requirements, there's testing that has to be done, and there's timing that just has to work out. So there are 2 sites open now, Duke and University of Michigan. We just opened 10 days ago, I guess. The first child who's treated at this higher dose level has to be watched for safety for a month, and then that data has to be collected and submitted and reviewed. So realistically, probably there's a 6 to 8 week window between the first child who gets that high dose and the subsequent kids who can get it. But the good news is the next 3 kids don't have a wait in between. They can be treated when they're available and ready. There also is, I think I have this on the slide. There also is a lot to do if you participate in the trial. You have to stay, I'll talk about Duke, at least 90 days, and then come back. I think it's 6 more times over 2 years. Forge pays for all that, the lodging, the travel, the testing, and everything that's done related to the protocol. But it's still a lot to commit to, and it's really, really important if you go onto the trial that you stay on the trial and do everything that's required. The hope is with these next 4 kids, the higher dose will be safe and will be the dose that is then taken to the FDA for what's called, a registration trial. Because it's a rare disease, FDA will only require 1 trial with a small amount of patients, and then it will be approved and available for everybody. I don't know how long that's going to take. It's always just whatever I hope. It's always way longer, to be honest. But I think probably 2 to 3 years is realistic. That next trial hopefully will have spaces for kids who are not just right after transplant, but are further out from transplant. But we're waiting to see, and we don't know. We know transplant has to be performed early in the infantile kids. We know it stops progression of disease in the brain. We know it does not do a good job on the peripheral nerves. The peripheral nerves get the sickest, the fastest in kids who have the infantile form. So with the older kids, the late infantile is kind of in between, and the juvenile form goes much more slowly, and the peripheral neuropathy looks different. And doesn't progress as fast. So we're going to have to figure out if gene therapy is helpful, will it also have a role in the later forms? If you have a transplant, it's a very complicated and risky procedure. Kids are in the hospital 2 to 4 months. They get a central line and a G tube. They get high dose chemotherapy because you have to wipe out or ablate the bone marrow, which is blood factory, and the immune system. Otherwise, the person who's getting the transplant rejects the donor cells. Recovery of the initial counts is a month or 6 weeks, depending. That's the riskiest period. But full recovery really takes 12 to 18 months. And there is a risk of a complication called graft-versus-host disease, where the new cells attack the person who got them, and then complications can go on for a longer amount of time. Fortunately, in the young babies, we don't see that very often, but it can occur, and it can mean that there's chronic problems that are not related to Krabbe. Also, and this has nothing to do with Krabbe, but kids who get chemotherapy as babies always have problems with their teeth because the teeth are forming, not only the baby teeth, but the adult teeth that you don't see, but are forming right in those first few months. So I know in the moment, you don't think about it, it's a good problem to have later, but it is a problem. And it does require dental reconstruction after a person is fully grown. There are special considerations for newborns with infantile Krabbe disease undergoing transplant. And when I talk to transplanters, which I do a lot, we talk about these things. But one, you need rapid diagnosis, and that's on the newborn screening labs. And Dieter in particular and Joe really are advocates for helping the newborn screening labs learn the fastest way to do this. The Newborn Screening Council is also a place that we discuss this over and over again. You should not wait for the genetics or the mutation analysis. You'll do it and it'll come back, but it could take weeks and you don't delay the transplant for that if the cycosine's over 10. Baby has to put on their own insurance. You probably don't even know when a baby's born, they're on their mom's insurance. You have 30 days to transfer them, and it normally doesn't matter. But if you don't transfer the baby to their own insurance, you can't get approval for transplant. So it has to be done early, and it's just one more thing that has to get done. I believe the baby should go to a transplant center for workup, be admitted, and get it done quickly. In most places, that's the fastest way to do it. You can find a cord blood donor quickly, but you have to have HLA typing. That can take anywhere you are 3 to 14 days. So that should be the first test that gets ordered so that you're doing all the other tests while you're waiting for that to come back, because you can't get the donor until you have the typing. And then the lines I mentioned, I believe all babies should get a G-tube. It makes their management much better. A lot of babies are jaundiced. You hear about newborn jaundice. In regular transplant, we wouldn't do chemo in a jaundiced person, but we don't wait. Newborn jaundice is not a danger. And so you don't wait for the bilirubin to come down. And you can start the chemo before the cord blood unit is delivered to the transplant center. That saves several days. Now, I'm going to talk a little bit about outcomes of transplant. Originally, Maria and I published a paper in 2005 looking at about 30 patients, 11 of whom were newborns who happened to be diagnosed because of a family history and got a transplant very early in life in the first month or two. And then there were a bunch of kids who were picked up when symptoms developed. So they were more between 3 and 10 months of age, and they were very symptomatic at transplant. In those early days, we had no idea. We were very hopeful transplant would fix the brain and babies would recover the function they lost, but that is not what happened. That's how we learned you really have to do the transplant early. I'm just going to show you a couple of figures from that paper. The top line is the newborns who all survived the transplant. The middle line is the symptomatic kids. This is showing, I think, out to 96 months. So the symptomatic kids had a lot of mortality from transplant and from Krabbe. And even though some of them continued to live, they did not regain function. And the untreated group, as you all know, died. And these are functional slides that show you in the colored lines that the newborns had good cognitive function, receptive and expressive language, fine motor function, but continued to have problems with gross motor function, which is related to the peripheral neuropathy. Maria published another paper that showed the same thing 15 years out. And then we published a paper looking at the day 2 transplant and how likely a child was to have better or worse function after 10 years. And the green bars are normal, the red bars are abnormal. And this shows you that kids who were transplanted before 30 days of age had more normal function. That included mobility, communication, and feeding. And the kids who were transplanted after 30 days had more abnormal functions. That's where this 30-day cutoff comes from. And it's true, but it doesn't mean 31 days may not be okay. It does mean 40 or 50 days is not okay. And to get a transplant in by 30 days is no easy feat because you have to do the workup, you have to find the donor, you have to have 10 days of chemo. So it's asking a lot of any group that's caring for these patients, but we have to make a roadmap that makes it work. As I mentioned, all the patients had problems with their teeth. Nobody had problems with vision or hearing. 70% were in school, but in a lower grade than they might have been based on their age. And I believe we need social networks for these kids as they get older. I'm going to take 5 more minutes because I really need it. I promise I'll end in 5 minutes. We've also looked at outcomes of kids diagnosed through newborn screening and the early data, which came from New York. And I cannot say enough about Joe Orsini, Mike Gelb, and those guys who did all the early work, because even though it wasn't perfect, we wouldn't be standing here today if they didn't do what they did, so we could learn and make it better. And they made it better too. But the early kids, there were 5, 4 went to transplant and 2 died in transplant. 2 are surviving, but both are fairly impaired. This is now 12 and 17 years later. We then went back and in the modern day of newborn screening with our colleagues at Nationwide Children's, Lurie Children's, at St. Louis Children's, and a Kentucky patient who came to Duke, looked at 6 babies picked up in newborn screening now over the last 7 years. We showed kind of how they got to transplant. The one thing I want you to take away from this slide, can you see my pointer? Yeah. The bar is 30 days. One baby, Peter's baby, got transplanted at 24 days. The others were all between 30 and 40 days. So we didn't hit the mark, but we got close and we learned a lot from it. All these babies had high cytosines between 24 and 73. All these babies had at least one pathologic mutation. And the take-home message here is that when we looked at development of these babies at a year, they were doing well in all domains except gross motor, big motor function. They were, they were already showing problems with walking and standing. We then looked at these same babies anywhere from 2 to 7 years later, and we saw exactly the same thing. That's what's up here. They were doing pretty well in the cognitive communication domains, but they were having trouble walking or not walking at all. And it's the same story over and over again. It's peripheral neuropathy. We have to find other ways to get it treated. We hope gene therapy is going to be the way. I'm also just going to show you a story. They're twins in New York. Their mom gave me permission to show their picture, who were picked up with an intermediate cytosine. It was 8. They had very low enzyme. They had one definitely pathogenic mutation and one we didn't know about. This is 7 years ago. We watched these babies all together very carefully. And at 15 months, the boy had a change in his MRI, and at 16 months, the girl had a change in her MRI, and so we went to transplant. They're both 7. They're twins, sorry, but they are great. And this, I just saw them a couple of weeks ago, and you can see their picture. They're little boys playing basketball and soccer, and they're just finished 1st grade. Point I'm making, and Dieter mentioned the intermediate cytosine, is that if we can figure out how we can identify these rare kids who are going to have late infantile disease and get them early, treat them when they have a problem, then we've made another kind of progress. And these kids don't have as much peripheral neuropathy as the early infantile kids. Okay, so I'm not going to talk about DUOC because, oops, we're still doing DUOC, but, and we don't know if it works, but we're doing a study in adults with primary progressive MS. We've enrolled 15 to 20 patients. And by next year, we'll know how DUOC is affecting myelination of the brain in people. We can't tell in the leukodystrophy kids because they also got a transplant. So stay tuned on that. And then I just want to thank everybody. There's a big universe of people who make me be able to stand here and talk to you, both at Duke and the transplant team and in the laboratories and in the cord blood bank. And then the investigators you all know in the Hunter's Hope team, I'll call it. And we've had support from lots of foundations, including Hunter's Hope and the Legacy of Angels and the Robertson Foundation and the Marcus Foundation to do a lot of this work. And I mostly want to thank you guys, you families with your kids, because we are all trying to make this better, and we have to do it together or we're not going to get there. This was a great year because we got Krabbe on the rest finally. So thank you. I'm happy to answer questions.